Okay, thank you, Millie, and thank you, Asher. It's a real pleasure to be here with you. I want to thank the meeting organizers and Steve and Rick in particular for, through the years, putting on such a great meeting, which has grown to this. I remember a time where the audience was about maybe a quarter or a fifth the size as it's become here now. This is it's really quite an achievement. However, and there's a big however here, I don't know how on earth I was given this title in this talk to present to you today. I do some administrative work at my home institution. I ride on people like Jean-Fred to make sure that they do 46 sessions a year on Wednesday afternoons so that he keeps up with his traveling. I make sure that all of my other colleagues spend a lot of their time actually seeing patients when they're supposed to be, and I have become something of a pencil pusher, much to everybody's, perhaps my own consternation, but we won't put my self-loathing into this talk any more than that. So I was thinking about this title, the volume of patients seen versus the value needed for each patient, and I thought maybe I should change it a little bit and make it how to bring value to your IBD patients and still keep your partners, your chief, your department chair, your dean, and your spouse and family happy, because I think that's really what I'd like to convey today to all of you. And I do have a couple of disclosures to mention. But really, this is a talk about nothing. This is, and we have Kramer somewhere here on the podium with us, and others. I'm not saying who's who. Asher. Good morning, Asher.
We'll talk back in New York, Tom. Or George.
That's exactly right. And we all know that Corey carries the title of Jerry here, and Millie, of course, is Elaine. So, on the one hand, it really is a talk about nothing. I really won't present too much data to you here this morning, but it's really a talk about everything. I think that we've come to a place here in the U.S. at least, and I'll have a slide on this later, where so much is going on that is so detrimental to our patients. Our costs continue to rise at unsustainable rates. Our efforts are enormous. Physician burnout is at an all-time high and is a very, very real and palpable problem throughout the United States, and certainly at our institution, though there really aren't any good metrics at this point to figure that out. So the premise really of the talk is that there's this conflict, or there's this real separation between the volume of patients that we see and the value that we deliver. I'd like to argue that there's really substantial, that there's a place where these things can come together, and that we can provide high quality, high value care to our patients, and that we can really do that to a larger number of patients than perhaps we used to 20, 30 years ago. We have to acknowledge that times moved on and that there have been some secular or calendar changes in what it is that we do, and still get to where we'd like to be. And I'd like to think that it looks a little bit more like this, and that the conflict between volume and volume really isn't all that great. So we're going to talk about volume first. Right, and we're going to start with a case presentation, and because of the small font, and I apologize, as calendar time moves on, I will put on my glasses. So, and this is a real live patient of mine from whenever it was that I first started putting this talk together, and he's a 22-year-old, and he's come to his follow-up visit with me with his mother. He has Crohn's colitis and a draining perianal fistula. He's had no real significant response to the anti-TNF therapy that we've had him on. We've had him on therapeutic azathioprine. That just means that the levels were correct. That's why the bunny ears around the word therapeutic that's there. He's previously been on methotrexate, hasn't had any benefit with that when it was on board with an anti-TNF. So he was changed to vedolizumab with azathioprine combination therapy. He's been moved up to every 4-week therapy with some Herculean efforts by some folks at my institution to get him on every 4-week therapy with his veto, but he's frustrated that he's not doing well. I had referred him to a surgeon. He had an appointment with the surgeon, loved the surgeon, hated the idea of surgery, and he really wants to figure out what we're going to do for him and how things are going to move forward. And of course, I recently relaxed my follow-up schedule from every 15 minutes to every 20 minutes because others in my practice were doing the same, and I figured, I've had every 15 minutes, I just can't do this anymore. And I started him 10 minutes behind on the day that I started writing this. And my next patient is a new patient who I want to put on a great first impression for. They're in the waiting room and scheduled to start in 10 minutes. So that's where we are here. And the game plan for this patient is to review the risks and benefits and alternatives to ustekinumab, which I think is my next play here, though I'm not 100% convinced that it's going to be so helpful. I want to review any clinical trial options with him that we have. I want to encourage that despite all these efforts that surgery may be imminent, though we don't have a time on it. I really want to examine him and do a good rectal exam, be sure that nothing's out of the ordinary there. I want to order up a follow-up MRI of the pelvis because I see now that it's been about a year since we've done one. And I want to get him lined up for a flu shot. I want to check some labs on him. I want to address every last one of his concerns and questions that he and his mother have, right? And I want to try and stay on schedule and the clock's ticking. And, just sort of thinking through this in my head, I've already wasted a good amount of time. So this is not an uncommon clinical scenario for any one of us, right? We deal with this every day. And we have partners, or we have jerky deans like me and other people beating down our necks, telling us that we need to do more and more and more, and we have less and less to do it. So we have to recognize that there are multiple stakeholders in clinical medicine at this point in time, and the patient really is and must be at the center. We're out there on the periphery along with the purchasers, and those are they're out there, the producers and the payers and their intermediaries, the insurance companies, pharmacy benefit, everybody surrounding the patient here, and they're each trying to provide value to the patient in their own way, but everyone's vectors or their perspectives, their points of view are all very different, and they're not lined up, unfortunately. That's the mess we've gotten ourselves into. So how do we manage this? Well, what are the real expectations for what we need to do as clinicians here as we're managing volume? Are they RVU based? Are they just strictly dollar based? And it almost doesn't matter if you want to crank out the RVUs or crank out the dollars. It's really the same phenomenon where you're going to make up for things in volume if the dollars or the dollars per RVU are down. What's the arrangement that you have, right? What are the expectations of how many RVUs or how many dollars you're supposed to bring in, and are there enough hours in your workday to get that done? Is your schedule realistic? Ultimately, I got so miserable doing every 15-minute patients that, and there were others in the practice doing every 20 for follow-ups, that I made that change. And you might want to think that too. What you don't want to be with your schedule is aspirational, where you're always behind, feeling pressured, and getting beaten upon by anyone else in your office. And it's just, I see, at least one person out here in the audience saying, yeah. So it's really important to be on time for yourself, for your colleagues, but really most of all for your patients. And something that you want to keep in mind is you want to regularly review what your profit margin is, what your downstream costs and revenues are, if you can get a grip on those latter two, because it's really important as you or your chief or as your IPA negotiates on your behalf for your contracts. And what it is you bring to a health system. It's important. So a very brief primer on RVUs, and there's a wonderful article on this that our colleagues Gil Melmed and Cy Katz put out about a year ago or so. And the RVU was really a creation of the 1980s, somewhere in between when ABBA was big and Guns N' Roses. And so while we've sort of turned over our musical tastes since that time, we really haven't turned over this system, and it still exists. Came out of the 80s really to sort of define what effort is and to help with Medicare expenses and payments and define physician work. It's modified for geography and some practice expenses, or at least the dollar per RVU is, and how much liability insurance costs as well. And that's how Medicare reimburses us for a unit of effort. And it's payer naive and can be applied across our health system. And this is what happens. A CPT code gets really gets paired with an RVU basis. And a level 3 follow-up gets you 0.97 RVUs. And that's it. There's no two ways around it. That's what it is. And so you can actually compare efforts across physicians, within physician groups, perhaps across departments based on RVU efforts. And these things can be benchmarked, and they are benchmarked, if you didn't know it, for how many RVUs a gastroenterologist who's working full-time should put out per year. And you can convert dollars per RVU. That's what CMS does, and that's what most of the third-party commercial payers do as well. But there are some important caveats, and that's really that this RVU system and this amount of effort really only defines or only works well in a fee-for-service environment. It doesn't tell us anything about the quality of work that we do, and it does, unfortunately, for some of us who like to think we do more cognitive work. I find it ironic that I do cognitive work, but that goes back to the self-loathing. The cognitive work that's there really gets minimized on an RVU basis. You get a lot more RVUs for cranking out colonoscopies than you do for cranking out follow-up complicated IBD patients. So in a fee-for-service environment and declining reimbursement, how do you make up for the lost income that's out there? Well, obviously you crank out the volume, and that's kind of the problem, if you can see that, and that's really what I'm supposed to be talking about today. Are you compromising quality by doing that? And if you are, you need to back off. Are you compromising the patient experience by doing that? Well, if you're running late, you certainly are. If you can keep on time and your schedule's okay, you're probably not. You can do all the things that you'd like to do. And if these expectations are too much, you have to ask your partners and chiefs for understanding. In reality, I suspect many of you out here in the audience are the sort of the IBD mavens within your own individual practices, and you take care of the tougher patients. And I'm looking out there and seeing some people who I know do that in their practices. And this is a real challenge, and you have to, you really need to discuss this with your partners, with whoever it is you report to. If you're in solo practice, God help you in 2016 and 17, but that's another discussion for another day. So it's not clear that the volume of patients really does affect patient experience. On the left, there's a publication that showed that the higher workload is negatively associated with patient satisfaction, but it's moderated by the relational climate, right? Stay on time, don't waste your patients' time, communicate well with them, make sure that the bathrooms are clean, and get good outcomes, and you'll be just fine when it comes to patient experience. And this was in some unpublished research that Greg Heatley, an ophthalmologist at the University of Wisconsin-Madison, put out. You can see in that upper right-hand group, there are a bunch of high-volume producers at his institution, really high-volume departments or groups that really have outstanding patient experience. So it's not all predictive. There's really no correlation that you can see there on the scatter plot. So the volume solutions: give patients the time they need, set and meet expectations of your patients, set and meet expectations of your partners. You can get there. Have a plan. Take the time to do pre-visit work, right? Know what you're going to do with each patient before they step in. You can change along the way, but set the battle plan before you walk in. And I'm sorry I used that metaphor. Set the engagement plan before you walk into the room. So this is something that I've taken to doing and is a really good use of time. You want to huddle with your MA or your nurse ahead of every session, review the schedule that's there, say, oh yeah, there's Mrs. Jones, she's always always so nice, and she's always doing so well. We'll be able to get through that visit quickly. However, Mr. Smith over here, he's really complicated. I might be taking a little bit more time with him. So when Mr. Rodriguez comes after Mr. Smith, and I'm running a little behind, you're going to have to go out and talk to him a little bit and just explain that I'm running behind, and offer him something like a cup of coffee or things like that. So you really want these huddles really work well and have saved me just countless headaches over time. Right-size the schedule. Frequent shorter visits are okay. You can bring patients back every month if they live nearby. You can do telemedicine. You can make frequent phone calls. You can do all sorts of things. You can set the agenda. It doesn't have to cover absolutely everything at absolutely every visit. And you want to delegate as much as you possibly can. And then you want to review those productivity metrics early and often and negotiate with your partners over how to proceed with things. And you want to do this to give your patients real value. which brings us to value. What is value? Well, there are lots of definitions that are out there, and the textbook definition, and the one I'm going to use, is that value is just quality divided by cost. And the perspective is obviously critically important based on who you are. And a key concept that you have to have in your head is what's the opportunity cost for what you're doing. That's the cost of what you could, or that's what you could be bringing back if you were doing something else. So the time and effort spent when you could be doing something else, that's the opportunity cost. And the value to the patient, so from the patient's perspective, it's really all about the outcome, the experience, and the time with the care team and physician. This is what the patients want in terms of quality. And the cost to them is how much they're actually shelling out, right? It's the copay, it's the out-of-pocket expenses for care and for travel, and it's the wasted time. It's the time that they come to and from your office. It's the time that they sit around in your office where nothing's happening. It's the time that they're sitting in the exam room twiddling their thumbs or reading their book on their iPad. Blessedly with mobile connectivity, many folks can get work done, but it's not their favorite place to do it. From your perspective, our perspective as physicians, as nurses, the quality that we're looking for is a really great patient outcome as well. So we're nicely aligned. We want the patient experience to be as good as it can possibly be. Our own experience is very important and isn't meant to be downplayed in any or all of this. One man's cost is another man's income. That's something I read every day in op-eds and the like. That's true here, right? So reimbursement is, we get benefit on the cost side here, so that's good. We want to bring in income, keep our practices going, take care of more people, continue to do the good things that we get to do every day. But time with patient is a true cost, and it's an opportunity cost, right? It could be seeing another patient, doing a colonoscopy, doing something else that's helpful for your group. And resource utilization is obviously a huge cost for us. There are other perspectives out there, as I mentioned, your physician partnership, your health system, your group. They're looking at outcome and experience as well. They're looking at waste costs, direct costs. They're also looking at that important downstream revenue that I mentioned before, and that's critically important as you put this all into play. The payers, of course, and that is either the insurance company that's the intermediary or the employer themselves, they care about outcomes. They want their employees and their employees' family members to be at work, right? That's what they want. And they do care about the direct care costs as well that have gotten out of hand. And this is really, this is the problem, and I apologize for the title. It's not meant to be insulting there. We suck at this in the U.S., right? I mean, Jean-Fred, are we providing that much better care in the U.S. than what you were able to provide in France? Of course not. It's just not even close. I mean, how did we get here, right? So our value, the value that we're supplying as physicians in the U.S., if we're not providing a measure of quality better than these other countries in the so-called developed world, then we're really providing lower value. We have to keep that in mind. And so what we're going to see over the coming years is our radical changes in the way that employers, in the way that the government, and in the way that the insurance intermediaries will pay for this. And so we're going to see that their incentives now, because we've made a mess of all of this collectively, we're going to move from straight fee-for-service in Category 1, and I know that you can't really read this very well, but you see some things highlighted or bolded down on the bottom. So Miguel's Medical Home is really an alternate payment model that's really based on a fee-for-service architecture, and it's really much more modern and takes quality and provides value to a much, much greater way than we have before. And we're going to move to really population-based payment over time. And this is really, I have to present to our CEO and the real dean on Monday, one of our slides taken from that presentation. So the federal government is changing all this. This is the grand experiment. Tom Price has not been happy with these kind of grand experiments, but hey, at least MACRA got rid of the SGR, right? And so we don't have to get those emails from our societies every January telling us that our payments and reimbursements are going to be cut by 23% or so. And that's been a nice bonus, but it's going to be replaced with all of this. So we're going to have to demonstrate quality over time or pay a penalty. It's going to replace meaningful use. It's replacing PQRS. It's got a practice improvement arm to it, which is kind of cool. But most importantly, though, in the trial training wheels year, which is 2017, there's not going to be anything with cost. Cost is coming, and it's become a bigger and bigger part of this. And here's what we're going to see over time. I want to thank my colleagues at Deloitte for providing me with this slide. We're going to see a shift from volume to value over time. And that's really where we're headed. And so my last slide, because I'm already 16 seconds over, how are we going to bring value to our patients? How can we do this right now while we keep our eyes on the changing reimbursement model that's out there, because the old one has been so poor? It's really about driving outcomes, right? Processes do drive outcomes, so it's important to do that. Corey and Gil had a really wonderful poster that was downstairs yesterday that showed all of the great things that they can do to improve quality, and most of that is driving outcomes that matter to patients. We want a decreased waste, right? Time is money, or as Billy Crystal famously said gosh, I'm having a little brain freeze here, in Spinal Tap, mime is money. So time, money, we really need to be conscious of these things at all times, and we haven't been. We've been conscious of our own money over time, and that's really, I think, been a huge driver in increasing that cost curve that I showed you. We need to communicate with our patients. We need to communicate well, often, in ways that they understand. We need to listen to them. We need to make the best use in the limited time that we have with our patients, and we want to make them full partners in the care. And I don't think that there really is a conflict between your schedule volume and patient value things when we do things right and when we do the right things. So that's all I have for you. I want to thank you for your time, and I'll sit on the panel and be a full member of the cast of Seinfeld.